My name is David Owens. I am a student of physical therapy at Regis University, and I am here to talk to you about special ways we can examine and manage patients with neck pain. The goal of this presentation is to provide a brief anatomical and neurological overview, to explain some specialized exam procedures for the deep neck flexors as well as cervical proprioception, and to describe interventions for those, as well as provide a conclusion as to how we can bring this into the clinic. Pictured here are two diagrams for reference as to how the cervical spine musculature attaches and originates on the cervical spine. The biggest aspect that I want to kind of touch over here is just this thought process behind describing cervical musculature as either being local or global. And we'll touch upon this later, but you can see here on the left the longus capitis and longus colli muscles sort of represent the more local, deep cervical musculature of the cervical spine, whereas the picture depicted on the right is more of the global cervical musculature of the posterior aspect. Key points for the neurological system that I'd like to touch upon are the muscle spindles. So just a brief review, muscle spindles are stretch receptors within the body that primarily detect changes in the length of the muscle, and they convey this information to the central nervous system via afferent nerve fibers. They appear to be extremely important in the movement dysfunction that we find in our patients with neck pain. And additionally, there's been a lot of research on the fatty infiltrate that embeds itself inside of this deep cervical musculature, and at times can be measured within 48 hours after a certain trauma, such as in whiplash. So given this combination of potentially having fatty infiltrate embedding itself within this deep cervical musculature, specifically the cervical multifidus, which you can see pictured here on the right, these may play a very large role in the reason why patients have chronic cervical spine impairments, which can be related to dizziness, balance loss, pain, or just the fact that they have decreased motor control of these muscles. Therefore, it is important for us as clinicians to try to figure out if our patients with neck pain have problems with these deep cervical muscles. The following are going to be two examples of how we can exam for these muscles and to create an outcome measure for ourselves. The first of these tests is known as the craniocervical flexion test, also known as CCFT. I will be linking a YouTube video that is pictured here from PhysioTutors, which I think is a fantastic resource. Just for a brief run through though, patient will be in hook-lying position. A biofeedback unit is placed under their cervical lordosis, right at the base of the occiput. The biofeedback unit will start at a pressure of 20 millimeters of mercury. You'll instruct the patient to perform a cervical nod, and you can go through an optional initial phase of the test to just see how high the patient can get in increments of 2 millimeters of mercury towards 30. But the real test is how long can they hold each of those increments, the goal being 10 seconds. The biggest thing here is to monitor for the superficial anterior neck musculature to make sure that they are not compensating, because the test is meant for those local, deep anterior cervical musculature that we talked about earlier. The second examination for deep neck flexors are the deep neck flexor endurance test, and I think this is a more common examination tool used in the clinic, given that there are no extraneous tools or other supplies needed. The patient is simply laying on their back, either in supine or hook-lying position, You'll instruct the patient to chin tuck and lift the head roughly 2 centimeters off the table. You're going to record the amount of time that the patient maintains this position without losing that specific chin tuck. And I've noticed based on research that the normalized scores for this test are very wide-ranging and even are different among men and women. So I think based on the way this test is performed, it's very clear that this is a more global approach, and it's not necessarily just the deep neck flexors that are being tested here. Just to touch briefly on the reliability of these tests, you'll notice that there is quite a bit of a larger range with the DNF endurance test that you see below there, whereas the CCFT above is simply much more reliable, both intra and inter-rater. It should be noted that other ranges of reliability were reported. However, on average, by and large, the CCFT was much greater in terms of their reliability than the deep neck flexor endurance test. So now that we've dealt with examining the cervical musculature, now we'll move on to examining the neurological structures of the cervical spine. The joint position error test is a way to examine cervical proprioception. Again, I've attached a YouTube link for a fantastic video from PhysioTutors. And again, this test is indicated for patients that have chronic neck pain related to a whiplash disorder, or potentially neck pain related to dizziness. What you're going to do is attach a laser to the head of the patient who is seated 90 centimeters away from a predetermined target. You're going to instruct the patient with a neutral cervical posture to close their eyes and move their head to an end range in one direction. And with their eyes closed, they're going to move their head back to where they think the center is. The clinician will measure the distance away from the starting point where they end up, and they are going to repeat the trial for 6 times. They're going to try to repeat this in bilateral cervical rotation as well as cervical flexion and extension. You can utilize the equation here that I've written out to calculate the degree of error on average. All you're going to do is take the arc tangent of the average amount of centimeters of air they have and divide it by 90 centimeters, which is the distance away from the target where they were sitting. Cutoff scores have indicated that a degree of error greater than 4.5 degrees suggests an impairment in their cervical proprioception. So now that we've covered ways to examine these cervical structures, let's talk about how we can intervene and manage these patients. A great intervention that we can use for the local deep anterior cervical musculature is to utilize that biofeedback unit and have them practice where they're at in terms of their ability to perform a chin tuck without compensatory strategies. Other common ways that we can induce strengthening of the cervical musculature is to take a more global approach and do cervical liftoffs. And a more low-tech option could be, again, to focus in on that more local cervical musculature to have resisted supine cervical flexion with the resistance against a ball or a towel. Another great one is to perform quadruped cervical retractions, which again are more of that global aspect of the cervical spine strengthening. And another way that we can challenge this exercise is to add resistance with a TheraBand, either again in quadruped or even in standing in a doorway. The interventions for dysfunction or impairments in cervical proprioception using lasers are pretty wide-ranging. You can always repeat the test examination strategy of simply trying to relocate the laser into what they believe is the center both using their eyes closed and open. Remember that using their eyes as they're open is an easier strategy, and you should progress to eyes closed. Remember also that the relocation strategy needs to be slowed down. If they start going fast, it can indicate the vestibular system, which we do not want to include. And remember that these efforts likely will need to be short duration, given that these patients will likely become dizzy with this sort of work. And we can always challenge them in a variety of different ways, whether they're standing or sitting on a stable or unstable surface, etc. And another great strategy that I have found to potentially break up the monotony of this exercise is to simply instruct the patient on following a specific maze, as you can see above here. And this essentially just increases the patient's ability to utilize those afferent messaging systems from those muscle spindles to hopefully increase their ability to relocate the laser with their eyes closed over time. You'll notice that in the previous slides I have not mentioned a specific exercise dosage, and my clinical instructor, Deanna Koncar at UCHealth, would be delighted to hear that there is no consensus on the specific exercise prescription or dosage of cervical strengthening. However, I think it's important to discuss the difference between approaches in strengthening either the local deep cervical musculature versus including a more global cervical approach. And there are RCT trials on both sides of this equation that indicate that both are helpful in managing patients with neck pain. And the question becomes, which type of cervical strengthening or rehabilitation technique should we take? Is it important to focus on endurance, perhaps a more high load classic strengthening approaches indicated, such as on the right, which you can see here pictured, are MedX devices that essentially are machines that force both the local and global cervical muscles to be involved, and it's a more high load, low rep scheme? Or should we more be concerned with the motor control and activation of these certain cervical muscles, or if we're just treating the cervical proprioception? To conclude this short presentation, we have to remember that the craniocervical flexion test appears to be more reliable versus the deep neck flexor endurance test. And again, it sort of distinguishes between that difference between testing the local versus global cervical musculature. The joint position error test and interventions using lasers is another tool that is not necessarily widely used in the clinic, but could be of great benefit to patients suffering from chronic neck pain and or dizziness. The cervical spine strengthening, along with typical manual therapy interventions, are most definitely indicated. Studies, regardless of if you attack the global or local strengthening of the cervical spine, definitely do help these patients in terms of their pain, headaches, or even their dizziness at times. So anecdotally, I think it's important just to give my best guess as to the best approach for approaching this question of how we strengthen the cervical spine. And I think that an approach that focuses on motor control of the local cervical musculature is indicated, and then from there progress towards a more global strengthening and endurance strengthening exercise dosage appears to be the most logical response to the debate, and that way we're integrating all of the different muscles that are in the cervical spine. So that concludes my presentation. I'd like to give a special shout out to my amazing clinical instructor, Deanna Koncar, at the Medical Center of the Rockies at UC Health, and I hope this presentation was helpful for those who are examining and managing patients with neck pain.